Hello my dear students, Assalamu alaikum. Hope you are doing good. I am Dr. Karim Rezwan Hasan, Associate Professor, Department of Anatomy, Newszonebd Medical College, Dhaka. As you already know that we have started the inferior extremity, and as a first bone we will today start femur. Before going for the details discussion, let me tell you femur is one of the most strongest and very heaviest kind of bone in our body. It is the longest bone of our body. In case of adult, the length of the femur is 45 centimeter or 18 inch. So you can understand how long it is. It is transmitting the body weight. Not only that, femur is the bone which is articulating with the hip bone to form the hip joint. That means from the upper trunk of the body weight is transmitting through the femur, then to the tibia, then to the ground. You know that femur is the commonly given bone in the professional examination. Now let's start. Over here you can see that this is a femur. In my hand I am holding in the left hand, that means it is the left sided femur. To hold the bone in an appropriate position, you have to remember or you have to keep in mind few things. That in an anatomical position, whenever a bone is held, you have to be careful that you are holding in a very appropriate positions. That means it has to be held in that way that it is present inside your body. Whenever you are holding the femur, not only femur but also any long bone, you have to fix the three-dimensional position. That means you have to fix the long bone superiorly, inferiorly, anteriorly, posteriorly, medially, laterally. Why? Because whenever a bone is present inside your body and you are standing in the anatomical position, you have to make sure that the bone is present in a very appropriate way inside your hand. That means whenever you are fixing the bone, make sure that its upper end and the lower end, the anterior surface or the posterior surface, medial aspect and the lateral aspect are kept in position. Now this is a typical long bone. That's why we have to hold the femur in a typical long bone way. Before proceeding to the femur, let me tell you that any long bone is having two ends and the shaft in between. Over here, this is the upper end, this is the lower end of the femur, and this elongated portion is the shaft. So you can understand that I am holding it in an upright position. Now let's see what is the anatomical position. This is the head of the femur. These are the condyles of the femur. So whenever we are holding the femur in an anatomical position, we have to make sure that the head should be present up and the condyle should be present down. Now let's see what is the anatomical position. For example, your teacher is asking you that tell me the anatomical position of femur. In that case, you have to say this is the left sided femur. It is having upper end, lower end and the shaft in between. The upper end bears head, neck and trochanters, greater trochanter and the lesser trochanter. The head is rounded and it is directed medially, upwards and slightly forward. The elongated shaft is somehow convex forward and it is directed downwards and medially. Over here you can see that condyles are over here. So these condyles are placed in horizontal plane. Remember one thing, whenever you are saying the anatomical position, make sure you are holding the femur on the horizontal plane, so that you can see that the shaft is not directed vertically downwards. It is directed downwards and little bit medially. So you cannot hold it like this. Make sure the femur condyles are touching the ground or horizontal plane. In that way you can hold the femur in a anatomical position. I am repeating the anatomical position again. This is the left sided femur. The upper end bears a rounded head which is directed medially upwards and slightly forwards. The shaft is cylindrical, which is little bit convex forward and directed vertically downwards and medially. The condyles are horizontally placed. So from these anatomical position, you can understand that the head is directed medially So, somehow we are fixing the bones in medial and lateral aspect. As I said, the shaft is convex forward, so somehow we are fixing the bone in anterior and the posterior aspect. And also we have added the upper end bears the head, that means we are fixing the bone superiorly and inferiorly as well. So, that will be the anatomical position. Now, let us start about the detailed discussion of each and individual part. We will start with the head. As we can see, this is the head. The head seems very much rounded in all aspect. You can see that it is very much rounded. It's look like a ball. Now, this head is connecting with the acetabulum of the hip bone to form the hip joint. You know that hip joint is a ball and socket type of synovial joint. So, over there the ball is head of the femur and the socket is the acetabulum of the hip bone. Now, over here we can see that this head is very much circular, but at the tip of the head or over here you can see there is a rounded depression. This depression is present below and behind the center of the femoral head, and this is called the fovea centralis. This thing is called the fovea centralis, and there is an attachment of this area. The attachment is the ligament of the fovea centralis or ligamentum teres femoris. This ligament is connecting this fovea of the head of the femur to the acetabulum, and it also conveys some of the blood vessels. Now, you can see over here very much close to the junction between the head and the neck, there are some small foramens. These smaller foramens are the vascular foramen. Through this vascular foramen, numerous small blood vessels are entering and supplying the head. So, we know that the head is having profuse number of blood vessels or enriched blood supply. So, what will be the blood supply of the head of the femur? Let us see. For understanding the blood supply, you have to know that this head is having blood supply from two sources. A very smaller portion close to the fovea, this area is having separate blood supply, but the rest of the very big portion of the head is supplied by the another sets of blood vessels. A small medial part of the head is supplied by the medial epiphyseal artery, and those epiphyseal arteries are coming from two sources. Arteries that is coming from the medial epiphyseal arteries, they are also coming from the posterior division of the obturator artery, and also ascending branch of the medial circumflex femoral artery. And the large lateral part of the head, the blood supply is coming from the retinacular branch of the medial circumflex femoral artery. But medial circumflex femoral artery itself is coming from the deep femoral artery. So, we can understand that this smaller medial part is having supply from the medial epiphyseal artery, which are coming from posterior division of the obturator artery, and also ascending branch of the medial circumflex femoral artery. But the large lateral part of the head, which is the main blood supply of the head, is coming from the retinacular branch of the medial circumflex femoral artery as lateral epiphyseal artery. Those arteries are passing through the neck. So, very obviously, if there is a fracture of the neck of the femur, then there will be interruption of blood supply of the head of the femur. So, there is a question like why the fracture of the neck causes the avascular necrosis of the head of the femur. That is a very important question. Now, let us discuss about the neck. You can see that constricted part just after this head is called the neck. Now, this neck is having some properties. You can see that the neck is not look alike every aspect the same. This neck is about 3.8 centimeter. Now, this neck is having anterior surface, then posterior surface, then superior border and inferior border. At the superior border, you can see that the superior border is very much concave and it is horizontally placed, but the inferior border seems very much straight and it is oblique. The anterior surface is connected with the greater trochanter or the shaft with a line that is called the intratrochanteric line. I have drawn a very faint demarcation over here. This is the intratrochanteric line. And at the posterior aspect, as you can see that the neck is connected with the greater and the lesser trochanter through the intratrochanteric crest. Remember, anteriorly intratrochanteric line and posteriorly intratrochanteric crest. So that is very important. Now we can understand that after the neck there is a very big lateral aspect of the bone we can see, and it is very much projecting. This big area of bone is mainly the greater trochanter, and a smaller projection like this is the lesser trochanter. But before proceeding to that, we need to know that this neck is having some of the properties and some of the functional properties. Whenever you can see that the upper part of the neck, the upper border, the thickening of the bone is over here. This thickening of the bone is called the calcar femorale. Calcar femorale is one of the strongest part of the femur which is supporting the neck. As you know, the neck of the femur is the commonly fractured area of the femur. That is why this neck is very much supported by a very thin segment of bone over here. This is called the calcar femorale. Now there are two functional things. Remember, if you put a line through the neck, then it is something like that. At the same time, if you put another line through the shaft, it will be something like that. So maybe you can understand this, there is an axis that can pass through the neck and there is an axis that can pass through the shaft, and there is an angulation over here. Obviously I can hold it like this. So there is an angulation over here, you can understand, it is very difficult to hold. The angulation between the axis of the neck and the axis of the shaft is called the neck shaft angle, and in normal adults it is 125 degree. In case of female, this neck shaft angle is little bit less just because of their wider pelvis. This neck shaft angle is very much important to maintain because it is helping for the total movement of the human being. Without the specific neck shaft angle, it is very hard to walk normally. Now another thing is that if you put an axis through the neck and if you put another axis through the lower end, then obviously if you put like this through the neck and from the lower end, if you just connecting them, there will be something like that, right? There will be something like that, and this time this angle is very less, about 15 degree. This is called the angle of femoral torsion. We usually say that the axis between the neck and the axis between the two condyles, if you connect them, then it will be the angle of femoral torsion, or it is very much important just because it is giving you an idea between the angulation of the upper end and the lower end, that is 15 degree. Now let us talk about the greater trochanter. The greater trochanter is having very prominent projection, that is called the apex. This apex is directed upwards and somehow it is also directed medially. This greater trochanter is having some specific properties, like it is having an apex, it is having a very prominent upper border, it is also having anterior surface, it is having a lateral surface which is quite bigger, and it is also having a medial surface. We can see at the medial surface there is a depression. Now let us describe. The projectile upper part, that is the apex of the greater trochanter, it is prominent, pointed, and it is directed somehow medially. The upper border is very much rough and prominent. The anterior surface is also rough. The lateral surface is somehow smooth, but it is having muscular impression and it is large. The medial surface bears a concavity or depressed area, that is called the intertrochanteric fossa. This depression is called the intertrochanteric fossa. Now another prominent is over here. This is the lesser trochanter. This lesser trochanter is also conical in shape and it is somehow directed medially and little bit backwards. If I hold it in an anatomical position, you can see that this lesser trochanter is directed towards me, that means it is directed somehow backwards. So in between the greater trochanter and the lesser trochanter there are two lines. I already mentioned those lines. Intertrochanteric line, which is extending from the apex upper border and it is descending down, very much faint line, and it is merging with another line that is present over here. You can see this is called the spiral line and it is going to the shaft through the spiral line. On the other hand, if you go posteriorly, this from the apex of the greater trochanter, a very thick prominence is there, crest like prominence is there, and it is going to the lesser trochanter, and this area is called the intratrochanteric crest. From the greater trochanter to lesser trochanter, a very prominent crest like area, that is called the intertrochanteric crest. You can see there is a very bony prominence present in the intertrochanteric crest. I have marked it so that you can see it properly. This is called the quadrate tubercle. This area is called the quadrate tubercle. Now the thing is that intertrochanteric crest is mainly extracapsular, that means it lies outside the capsule of the head of the femur, but intratrochanteric line is somehow it is providing attachment to the capsule, that is the joint capsule of the hip joint. So this is very important. Intratrochanteric crest is extracapsular, that means it lies outside the capsule, but the intertrochanteric line is intracapsular. Now let us go for the shaft. In the shaft, for the proper discussion, we have to divide the shaft into three parts: upper 1/3, medial 1/3 and the lower 1/3. The shaft is very much cylindrical. We will start from the medial 1/3, just because the medial 1/3 is having very simpler properties. In the medial 1/3 you can see that this is cylindrical, but posteriorly there is a very prominent ridge, which is actually splitted downwards and also it is splitted upwards. This prominent ridge at the medial 1/3 of the shaft is called the linea aspera. I am repeating again, it is called linea aspera. Now this linea aspera is considered to be the posterior border of the shaft of the femur. Now over here this faint area is called the medial border, and over here that is the lateral border. So femur at the medial 1/3 is having medial border, lateral border and posterior border or linea aspera. So it is also having three surfaces, that is the medial surface that is present in between the posterior border and the medial border, and the lateral surface that is present in between the linea aspera or posterior border and the lateral border, and obviously in between the medial border and the lateral border, this surface is called the anterior surface. So at the middle 1/3 of the femur is having anterior surface, medial surface, lateral surface, and three borders: medial border, lateral border, and posterior border or linea aspera. Now what about the upper 1/3 and the lower 1/3? In the upper 1/3, if you can see that linea aspera is splitting into two lips, that is the lateral lip and that is the medial lip. You can see that the medial lip is merging with the spiral line and the lateral lip is going to the greater trochanter. So in between these two lips, this area is considered to be the posterior surface, and as gluteus maximus muscle is attached over here, that is why this area is also called the gluteal surface. At the other hand, this is the medial border, this is the lateral border as usual, and obviously the borders are medial border, lateral border, lateral lip, and the medial lip or spiral line. So the surfaces are medial surface, lateral surface, which is the lateral surface is over here, lateral surface, medial surface, lateral surface, anterior surface, and in between the two lips there will be the gluteal surface. So at the upper 1/3 of the femur is having four surfaces and the four borders. The borders are medial border, lateral border, and the surfaces are anterior surface, medial surface, lateral surface, and the gluteal surface or posterior surface. Now at the lower side you can see that the linea aspera is again forming two lines which are very much connecting to the supracondylar areas. You can understand this is the medial condyle and this is the lateral condyle. So this is the lateral supracondylar line and this is the medial supracondylar line. So from the linea aspera, the medial lip is going to the medial supracondylar line and lateral lip is going to the lateral supracondylar line, and in between these two lines, this surface is called the popliteal surface. This area is called the triangular area, this is called the popliteal surface. At the other hand, still it is having the medial border, lateral border. So at the lateral 1/3 there are four borders and four surfaces: medial border, lateral border, medial supracondylar line, lateral supracondylar line. So the surfaces are medial surface, lateral surface, anterior surface in between the medial and the lateral border, and popliteal surface in between the medial and the lateral supracondylar line. So from this complicated discussion we can understand at the shaft the three segments are upper 1/3, middle 1/3, lower 1/3. The middle 1/3 is having three border, three surfaces, but the upper 1/3 and the lower 1/3 is having four borders and four surfaces. We will discuss in details about the attachment of these areas and borders and everything. Now let us finish with the lower end. We can see that the lower end is having two condyles, two big condyles, medial condyle and the lateral condyle. In between the medial and the lateral condyle there is a very depressed area, as you can see, very big notch. This is called the intercondylar fossa or intercondylar notch or intercondylar fossa. At the same time you can see that the anterior aspect of these two condyles are somehow is present a area. This is called the patellar area. Patella is attached over here. That is also known as patellar surface. This area is called the patellar surface. So, these two condyles are having a patellar surface anteriorly and posteriorly intercondylar fossa. Now, very much projecting portion of this medial condyle, this is actually called the medial epicondyle, and over here at the lateral condyle you can see another projection, this is called the lateral epicondyle. So, the medial condyle is having the medial epicondyle and the lateral condyle is having the lateral epicondyle. Below the lateral epicondyle you can see there is a depressed area over here, this is called the popliteal fossa over here. This is the popliteal fossa because popliteus muscle is attached over here. The origin of the popliteus is happening over here. This small area is called the popliteal fossa. Do not confuse it with the popliteal surface. This is the popliteal surface, but this is called the popliteal fossa at the lateral condyle below the lateral epicondyle, and this is called the muscular impression. This muscular impression is important for the attachment of the muscles. At the medial condyle, this projection is called the adductor tubercle. This projection is called the adductor tubercle, which is present below the medial epicondyle. This adductor tubercle is important not only for the attachment of the adductor magnus muscle, but also it is important because the epiphyseal plate which was present over here during the developmental period, that epiphyseal plate was present at the level of the adductor tubercle, and adductor tubercle also indicates the line of fusion of the epiphyseal plate. You know that in case of femur, the growing end is present at the lower end, and that growing end represents a epiphyseal plate, and that epiphyseal plate is present through the adductor tubercle. We will discuss in details about the clinical condition of that thing. So, today we have already discussed a lot about different features of the bones. So, in the coming days we will discuss about the attachment of the femur. So, till then, thank you very much. Stay safe.